This conference will now be recorded.
Okay, so management of trophoblastic disease. This is Green Top Guideline number 38, and it was like updated in September. Like that. Okay? So this guideline is very important for you to remember. Why? Because you should have like clear concept what exactly is happening and how you are going to identify this condition, how you are going to treat this condition. So first of all, you should remember that gestational trophoblastic disease, this is like a group of disorders, and it includes both pre-malignant and the malignant conditions. That is important for you to remember. So the gestational trophoblastic disease is a group of disorders ranging from the benign, pre-malignant to the malignant conditions like that. And then it can occur anywhere. Like if we talk about the different like the spectrum, it can be like complete, there can be partial mole, and also there can be the partial mole is also called hydrately deformed mole like that. Or it can be malignant, like there can be invasive mole, choriocarcinoma, placental site specific trophoblastic tumor, and it can be epithelial trophoblastic tumor also. Then GTN, gestational trophoblastic nucleasia. It means there is persistence of the gestational trophoblastic disease after primary treatment, and so after primary treatment, still we have high levels of beta HCG. That's why this condition is persisting like that. Then in conditions here, we need histological confirmation. Why it is required? Because basically we are not trying to exclude any gestational trophoblastic nucleasia there. That is the exam. Okay, so that's why we want to exclude that, and we are talking about the histological examination. Then in cases of complete mole, partial mole, or atypical like this one PSTT, like placental site trophoblastic tumor, or like the epithelial trophoblastic tumor, or in cases of like a persistent trophoblastic disease, here you need to do that. But if there is like placental site specific trophoblastic tumor, in all of these we don't need that, but we need to have the like this for the gestational trophoblastic nucleasia. That is important. Okay. So if we talk about the background of the moles, then you should know that moles, they can be of like different types. Like there is comparison of the complete and the partial mole. Okay. So for the complete partial mole, you need to remember there is an easy way of remembering it. We say that the complete mole is totally devoid of the baby, and that is androgenic in the origin. We are not going to see any fetal tissue, and 75 to 80% they will arise due to duplication of single sperm after fertilization of an empty ovum. So no genetic material from the mother, only cases of androgenic or the paternal origin, because one sperm entered and it divided into two. And then 20-25% they will have dispermic fertilization of an empty ovum. So if you will recall, the baby is formed from birth, baby is formed from the maternal DNA. Mother has the code for the development of the baby, and the placental tissue, it is formed from the father's DNA like that. Okay, so if it is not there, then there can be problems like that.
So basically, the complete mole is only paternal origin.
Only, yeah, it is androgenic because mother's egg was empty. That is totally androgenic of the paternal origin. That is the point. And in like 70, these are all SBAs. Okay, 75 to 80% they will be due to the duplication of the single sperm after fertilization of an empty ovum. And
so
then 20 to 25. One sperm enter, the genetic composition will be 45x0 like that. Why? Because
so what is the difference? Sorry to interrupt you, Dr. Aisha. Sorry. So what is the difference between the 75 to 80%, which says due to duplication of a single sperm, and the 20 to 25 due to dispermic fertilization? Is it not the same?
No, they're not the same. Here what happened, here there was an empty ovum and single sperm entered, but after this single sperm entered, it divided into two. Why? Because the maternal egg was not fine. So if the egg was there and the things were intact, then once the sperm has penetrated the zona pellucida, then no more sperms they cannot enter, and once the sperm has entered the cell, then it should stay as it is. And if you will remember, the whole sperm is not entering the maternal zona pellucida. What is entering the zona? Only the pronucleus, which contains the genetic material. Okay, so it should not be dividing. But here what happened, that it entered and it divided into two. So now in the complete mode, what exactly is happening? Why this number is X046? Because if you remember, the sperms and the ova, they carry single number of chromosomes. Each will carry 23. Why it is so? Because 23 chromosomes are coming from the mother and 23 single chromosomes, right? 23 are
Yes.
coming from the mother, 23 are coming from the father. So when they will combine, then the number will be restored, and that will be 46. That is the point. Okay. So one sperm entered, and the second one, it also, and then the one divided into two. So this ideally, when there is no maternal ovum, empty ovum is there, right? So the chromosomes, empty ovum, so no chromosomes, so number will be 0, right? But now you got a sperm which divided into two. And I told you that basically only genetic material is transmitted inside the egg, ova, like that, okay? So one sperm divided into two, 23 plus 23, we are getting the number 46x0, right? Because the mother's ovum is empty, no genetic material, okay? So 75 to 80%, they are occurring due to duplication of the single
Sperm.
single sperm. Then 120 to 25%, here the two sperms, they entered the maternal empty ovum. So again, what will be the chromosome number? 46x0, right? Because the mother's egg is still empty. But now we have got two sperms, so 23 chromosomes, single chromosomes from one sperm, 23 from the second sperm. So again, the genetic composition is 46x0. Is it clear now?
Yeah, it's clear now. Yeah, thank you.
So complete mole is completely devoid of the baby. Baby is not there, completely missing. Now to the partial mole. Triploid. Triploid, like 3 sperms are there in 90%. Okay. Then tetraploid or mosaic, that is seen in 10%. And here fetus or the fetal RBCs are present. Like triploidy means that we have 3 germ cells. Okay, it can be 2 sperms and 1 ovum, because in partial mole you are getting both. In partial you are getting the maternal DNA and you are getting the paternal DNA. And usually what will happen? Three haploid chromosomes, 2 sets of the paternal haploid and 1 set of the maternal haploid chromosomes. Haploid, I mean carrying 23 chromosomes. So what is the partial mole genetic composition? 69. XX can be 69 XY. 69 XY. That would be the composition, right? So the now maternal 23 chromosomes are there.
It will be, it will be 69 XX and 69 XY?
No. 69 XY, because mother is contributing just one, okay? So as the number of the sperms will increase, then it will increase, like can be XYY, that can be there, okay? But just remember that there are going to be 69 haploid chromosomes, total 69. 3 from mother, and then 23 plus 23 from the father. And if it is tetraploidy, then again another set Y that will be coming from the, can be 20, can be triple like X also, because they're coming from the sperm. So you know, from the sperm can be X, can be Y, but the number is important, 69. Here the number is important. In the complete, 46. Partial, 69.
Okay.
Can be even more, but 90%, 69. So here, since the maternal DNA is there, so baby is going to form. So when the baby is forming, then we are getting the maternal, the baby's tissue. So the fetal RBCs will be there. That is why if there is miscarriage or something, then we will have to give NTD. Here we had no fetal tissue, so no need for NTD or anything like that. So not all triploid or the tetraploid pregnancies, they are partial moles. They must have like histopathological evidence for the diagnosis. Histopathological evidence is very important. If there is no histopathological evidence, no benefit like that. They are very keen of asking about the incidence. So uncommon in the UK, but it is seen in 1 in 714 live births, and the incidence is higher in the Asians, and the incidence is like 1 in 387 live births. Non-Asian, the new guideline says 1 in 752 live births, and it is associated with the age at conception and higher at the extremes of the age. Like the age is less than 15 years, then the incidence is going to be 1 in 500 pregnancies. And if the age is more than 50 years, then the incidence is going to be 1 in 8 pregnancies. So you know that's why it is very, very important like that. Okay, that is the point. So then it may develop after molar, non-molar pregnancy, or even absolutely normal live birth. Even after that, they can develop this gestational trophoblastic nucleasia. So what is the incidence that somebody can have it? 1 in 50,000 after live birth. So on an average, a consultant is likely to see like one case every 2 years like that. So for the registration, you know, you are working in the systems, you know that they have to go for special centers, and with the chemotherapy, the treatment success rate is going to be 98 to 100%. And chemotherapy, it may be required. This is also SPA question. So chemotherapy is required in how many of the patients? 0.5 to 1% after partial mole, and after complete mole 13 to 16%. There is a shift here. Before we used to say that 0.5% after partial mole and 13 to 15% after complete mole, but now 13 to 16% after complete molar pregnancy like that. This is the incidence of giving chemotherapy. That is the point. Okay. So very important to register these patients to the specialist center. Why? Because here they can be cared for better. So registration is required as a minimum. Why registration? Because we don't know that what exactly will be the outcome of the patient. So that's why we need to be very careful like that. So what is the, how does the molar pregnancy presents? So do you remember seeing a case of molar pregnancy? What happens in the molar pregnancy? Any idea? The normal, the usual presentation.
They can present with like excessive bleeding, or even as we said in the hyperemesis, they can have like hyperemesis as well. But usually after miscarriage, they come with the continuous bleeding. Like this is one of the presentation of their after the miscarriage.
Bleeding, or maybe because usually they will come when they have like this mild bleeding, so they will come to the hospital. Most common presentation is irregular bleeding, which is like almost 60% patients, they are going to present with abnormal uterine bleeding like that. Okay. And then we will do the ultrasound, and ultrasound will be positive in like just 12% of the population. We are going to see the snowstorm appearance. Then less common symptoms can be hyperemesis, excessive uterine enlargement, and then the hyperthyroidism. So early onset preeclampsia can be there, and then patient can have like there can be huge thecal uterine cyst, and patient can have abdominal distension or discomfort. Very rarely, if the lungs have been involved, then the patient can have hemoptysis, or she can also have seizures, like if the brain tissue has been involved, like the you know the bunches, they have detached and they have entered the CNS, the circulation like that. So ultrasound is very important, because what is the benefit of ultrasound? Ultrasound, you know, it has helped us in finding the diagnosis earlier, like we can diagnosed from 16 to 9 weeks, like that. Okay? Before, mean gestational age was at 16 weeks at diagnosis, but now with the ultrasound we are able to diagnose at 9 weeks. Okay, then majority of the histologically proven moles, they are associated, in case when we will do this ultrasound diagnosis, then we, in cases of delayed miscarriage, like the missed miscarriage or an embryonic pregnancy where the baby didn't develop, so then we can suspect them that histologically they are mole. So if the cases of missed miscarriage or an embryonic pregnancies, we have to carry out ultrasound. Then we can say definitely that this one is a molar pregnancy. First, we will exclude the diagnosis like that. Then pre-removal, what we have to do, accuracy of the diagnosis increases with the gestational age. Like if the woman is coming to us before 14 weeks, then the chance of diagnosing on ultrasound, that is 35 to 40%. But if the patient is presenting after 14 weeks, then with the help of ultrasound, the chance of diagnosing will increase to 60%. That is one point. Okay. Then we should remember that ultrasound also has a question that how many patients they can be diagnosed correctly with the ultrasound. So almost like 56% of the molar pregnancies with suspected miscarriage. So ultrasound can identify them. 56% cases of the molar pregnancy, they can be diagnosed as suspected miscarriage, where the baby has stopped to grow like that. That is one
But
thing.
is this only on the complete molar? Yeah, because the partial molar, we said that we need the
Yeah,
histopathology.
we'll talk
Yeah?
about it. As we will go through the guideline, we will see that the guideline says that yeah, we will have to go and we will have to that is for the complete, but for the partial we will have to use other things like that. So then 2.7% of the cases of the molar pregnancy, gestational trophoblastic disease, they will be totally unrecognized. We will not know about them and the patient will be having this molar pregnancy. So ultrasound features of suggesting of this complete molar pregnancy, they will show us a polyploid mass between 5 to 7 weeks, and there will be thicker cystic villi tissue after 8 weeks and no identifiable gestational sac. So this finding is like 95% sensitive and it has positive predictive value of 40%. Why? You have done the ultrasound and you have seen a polyploid mass, and which is like, and you have carried out this ultrasound between 5 to 7 weeks, and there are like thick villus tissue is present after 8 weeks and no baby is there. Okay, that is the appearance in cases of complete mole. Now if you have a partial mole, you will see enlarged placenta, or there will be cystic changes or lacunae within the decidual reaction with empty, either the sac can be empty or there can be like delayed miscarriage. That is one thing. Then ultrasound, it will correctly identify 88% of the complete moles and 56% of the partial moles. SPA questions, okay? 88% of the complete mole and 56% of the partial moles. Then diagnosis of the, if we talk about the diagnosis of the molar pregnancy, then definitive diagnosis that is achieved only on histological examination. Okay, and like the features of the histological examination, I said that there will be no, in the cases of a complete molar pregnancy, there will be no fetal tissue and hydropic changes to the villi and excess trophoblastic proliferation. Then in cases of the partial molar pregnancy, we will see that the fetal tissue is present and changes to villi are also there and some excess trophoblastic proliferation. Then to distinguish complete from the partial mole, we should know the ploidy status. What else can be used in addition to the ultrasound? Because ultrasound is just screening, okay? It is helping in the diagnosis, but this is not a specific diagnosis. So what will be the specific diagnosis in such cases? We will see the immunohistochemistry staining for P57, that is also found to be helpful. That is one thing. Okay? So these are the diagnostic techniques. So what we should do? So the pregnancy is there. and it is not good. So we need to remove this pregnancy. Why this pregnancy? Because this is not going to progress very well, because this is abnormal. So suction curettage, that is the method of choice irrespective of the size of the uterus. So usually we are avoiding medical removal because 16% increased risk of gestational trophoblastic neoplasia and the need for chemotherapy in cases of complete pregnancy. Like you have done the ultrasound and only the sac is there, baby is not there. So this is just a complete mole. So if we are offering her like the misoprostol, then we should know that it is not a good option because there will be contractions and this neoplastic tissue, it will enter the maternal circulation because the chance of having gestational trophoblastic neoplasia in cases of complete molar pregnancy, that is very high. That is almost 60%, 16 times higher as compared to the normal pregnancy. So that's why we will say that we should not offer anything like that. Okay? So 16 times increased risk of gestational trophoblastic neoplasia in cases of complete molar pregnancy. And she will need chemotherapy. That's why we don't want to do anything for them. Then higher rate of incomplete removal with the medical method. Then ultrasound guidance during procedure. It is useful to decrease chance of perforation and to ensure maximum tissue removal. Because you know this is also a concern that there can be perforation of the uterus. That is the point. So then the partial mole. In the partial mole. So what do you think, which method can be used in the partial mole?
The suction.
Again, suction evacuation. Why suction evacuation? Why we don't want to cure? Why do we don't want to do like evacuation?
Because of the dissemination of the trophoblastic tissue can go into the blood.
Yes. Yeah. That is the problem. So we don't want to have this problem. That's why we will not offer sharp curettage. So we are going for the suction evacuation because the purpose is to remove the baby from there, right? Not to like curate the uterus. Our purpose is to remove the tissue from there. So then in cases of the partial mole, we should know that suction curettage is the method of choice, except where we cannot offer this one. If the size of the baby is large, and then there can be problem because the bony tissue is there. So theoretically, it can cause bony tissue of the baby is there. So it can cause perforation, injury to the uterus. That is the point. Okay, that is one thing. So then if we have like removed the tissues, if the size is large, then what we will have to do, we will have to use something for priming the cervix like that. So anti-D prophylaxis is recommended after removal of the molar pregnancy. So what is the type of either type for the practical reason, because in the real life we are giving even after complete, but usually after complete, for the sake of exam, after the complete molar pregnancy, we don't have to give. So but if the suspicion is higher, like there can be like anti-D required because their blood groups are different, then we can offer them. So twin with one normal and other molar. So what should be done? Or there is demise of the coexisting twin, then in the women she decides for termination of pregnancy, then medical removal it may be used. Like in cases of the twin, and the woman is requesting that we should remove this pregnancy. Why? Because the one is molar and the one is normal and the second one is molar. So here also we can offer the medical termination if he is deciding for the termination of pregnancy. That would be the indication for the using medical treatment. So cervical preparation should be offered. We are giving the cervix on the same day. We are giving it vaginally. We are giving prostaglandins. We can also give dilators, but usually we are preparing the priming the cervix with. We are priming the cervix with. Mostly we are priming with a prostaglandin, because if we loosen the tissue, the shape will change. So why? Because we want to enter the instrument safely. This suction cannula, don't want to have resistance. Otherwise also if there is resistance, then you should stop it so that to decrease the risk of perforation like that. So we should know that this cervical ripening, as the guideline says, it is not associated with increasing the risk of gestation trophoblastic neoplasia or requirement of the chemotherapy. That is one thing. Then use of oxytocin. We don't want to use it because it can also cause dissemination of these moles into the maternal circulation. They can go and they can cause DIC like that. That is one of the things. So they can cause embolization like that. So oxytocin infusion is not recommended prior to complete removal of the products of the conception. Or if there is excessive vaginal bleeding, then of course you will have to use the oxytocin, but it should be started only on the orders of some consultant like that. Okay?
So this
if
is
there is
the
bleeding,
so we are not using the oxytocin in the partial, yeah?
you have a partial or removal of the complete in any form. But the point is
In any
that
form.
this is for all types. Why we don't
Mhm.
want to use? Because it will cause like embolization of the bunches or the moles into the maternal circulation. That is one thing. But if the woman is having hemorrhage, then you need to tell them. Usually these procedures, you must have seen that these are carried out by the consultants, right? So the
Yeah.
consultant is going to do this process, and if there is like hemorrhage, then he will do this risk benefit analysis and he can use this syntocinon. So syntocinon as such, we cannot say that this is contraindicated,
Yeah.
but advisable that we should not use.
Not use it, yeah.
And
Okay.
but if there is hemorrhage, then you cannot let your patient die with hemorrhage, right? So in that case, you will have to give oxytocin. That is the point. So such procedures, they should be done by the consultant. And if there is excessive bleeding before or during the removal, then they should expedite the surgical removal. And then the consultant can start oxytocin after risk benefit analysis like that. Regarding the indication and timings of the repeat surgical maneuver, surgical removal, so it can be urgent, like the patient has bleeding. In that case, you will have to do it like as an emergency procedure, so it can be repeated. Why? If the patient has like heavy bleeding or persistent vaginal bleeding and which is leading to acute hemodynamic instability. Then if we know that patient is having bleeding, like she's passing blood clots, and if we don't do the repeat procedure, then she's going to die. Why? Because she has severe bleeding like that. So in these situations, we can consider balloon tamponade. Why? Because we want to compress the blood vessels so that bleeding will not occur like that. So if that is not
Yeah.
possible, then we will think about the uterine artery embolization also, that it can be stopped. Why do we want to do these balloon tamponade or the uterine artery embolization? Because we are trying to prevent the patient for hysterectomy. Because in real life, there are many case reports that we started the treatment with the molar pregnancy and the patient had torrential hemorrhage and ended up having hysterectomy. So that's why on such procedures, the consultant has to be inside or rather consultant has to do these procedures. So secondary is, what is the role of second removal if HCG is less than 5,000 international units like that? So we will say that the trials have shown us that if we are doing second removal, then in 40% cases, we will not have to give any type of chemotherapy. That is one thing. Like the patient was bleeding, so we have given her, carried out the second evacuation, and now this patient may not need chemotherapy like in 40% of the cases like that. Then in some cases like 1 in 3, or we can say like 10%, they will have like different histological findings on second removal. That is also a SPO question, that 1%, what percentage of the patients is going to show a different type, like you have done the first evacuation, one histopathological report, right? And second one, you have done the same procedure and now the histological report is different. So they can ask you that what has happened in this type like that. So it is possible in 1 in 3 patients we can have the same findings, like the 31 in 1 in 3 or 3 in 34. These are the results from the trials like that. Okay, that is
Sorry,
one.
Dr. Aisha, could you repeat this last bit you said?
Yeah. Yeah, you did first evacuation and you did
Yeah.
histopathological examination, and you classified on the basis of histopathological examination, histological examination. You said that she has molar pregnancy, okay? Complete molar. Then you carried out the second evacuation, and then histopathological report showed, histological analysis showed that this is a partial molar pregnancy. So you imagine that how important it can be. Like 3 in 34 patients in a trial, they had a different findings on second removal. SBA question like okay, that is one thing. So is it clear now? First time you got this molar pregnancy, right? Complete molar. Second time you didn't, and on the histological examination you found that this is partial mole or this is persistent central site trophoblastic tumor. So different pathology can be there. So you have to be careful about it like that. If you're doing the second time, don't think that we have sent the sample first time. So we should not be sending the second time. So it doesn't matter in the second time also you need to send the sample. That is the point here. Okay? So it can
Okay.
change your diagnosis also like that. So histological examination for the diagnosis, it should be done after miscarriage, like the recommended to have, like the patient had a miscarriage, then histological assessment of the material obtained in all types of miscarriage, whether it was medical, surgical miscarriage, if no fetal parts were identified at any stage of the pregnancy. Then if no tissue was sent for histopathological examination, in that case, you need to repeat the urine pregnancy test after 3 weeks. Okay. So first, after all miscarriages, you should send the tissue for histopathological examination. And if you're not sending for histopathology, then you need to run urine pregnancy test after 3 weeks. We do this for all patients like that. Okay.
Yeah.
So if the urine pregnancy test is positive after 3 weeks, then we have, this is an indication for serum assessment of the level till it starts falling and it becomes like 2 international units, drops to the baseline. Till that point we need to follow her up, and if any case the beta hcg level it stops falling, then what we will have to do, we will have to arrange ultrasound for the pregnancy tissue, and we have, if we found to remove any tissue, we need to send for pathological examination. Now this is after miscarriage. So after miscarriage, sometimes no need to routinely send pregnancy tissue after therapeutic abortion, provided fetal parts were identified on ultrasound or on surgical removal. In first condition, when we are doing the serial beta ICG, here if we didn't see the fetal parts, okay, so don't confuse two conditions. First condition is in which we saw no fetal parts. So send the tissue for histopathological examination. If we are not sending the tissue for the histopath, then we have to repeat the urine pregnancy test after 3 weeks. That is the point. Okay. So if after 3 weeks urine pregnancy test is positive, then we need to do the serum levels should be checked again. Why? To ensure that there is a drop in the serum beta ICG. But if the serum beta ICG levels they are not falling, in that case we will have to arrange ultrasound for the pregnancy tissue. That is the point. Okay. So all tissue
This
has been
conference
seen.
will
In
now
that
be
case,
recorded.
you don't have to send them the products of conception for histopathological examination. Why? Because we already saw the tissue when the baby was expelled like that. Okay. But why? Because it has been documented that baby was seen before. So now we don't have to send the products of conception for histopathological examination. That is the so
But
then
is it not in the table we said that the partial we have to send for confirmation for histopathology?
yeah, if we have seen the tissue, then we don't have to. If we have not seen the tissue, then we have to send for the histopathological examination. That is the point. Okay. But if like in the partial you have seen the fetal tissue, so then you don't have to send. That is the point. Partial mole, why we'll say that it is not like, maybe we said that the partial molar pregnancy, can also present as a case of missed miscarriage, that the baby was there, the CRL was 6 week, and then the baby died like that. But at least we have seen the tissue. We have seen the embryo, so that we don't have to do anything. Is this point clear? Because even in the partial, you have seen the baby. Or maybe if you are diagnosing at 13 weeks, the bones are already there, so you don't have to do anything for it. Is
But
this
then
point clear?
how we will confirm that it's a partial molar pregnancy without the
Because
histopathology?
you have seen the baby and now you are seeing the moles also, like that. That is the point. We were talking about the fetal tissue. We have seen, we are not sent. We have not seen, then we are going to send the tissue. This is what the fetal parts like that. Fetal parts were identified at any stage of pregnancy. That is correct. You don't have to send. But this is not. This is no. We are not. This is Amal. We are not talking about on a background of the general background of the this one on this, not exclusively about the GTD like that. In all pregnancies, do you send the tissue or we don't? We send the tissue, right? Why? Because we want to exclude the things. That is the point. But if you partial, you are diagnosing because you are seeing the swollen placenta and then you are seeing the fetal tissue. So if you have seen the fetal tissue and hydropic stuff, in that case, you can start the, you can say that this is like the partial molar pregnancy. So the point is that if any case you have seen the tissue, then even you can hold that point like that. Why? Because the ultrasound, the fetal tissues, they were diagnosed before removal or after, or they were seen on the ultrasound. Documentation should be there like that. That is the point. Okay. So if the patient had like miscarriage, then no need to routinely send pregnancy tissue after therapeutic miscarriage, provided fetal parts were identified at ultrasound or surgical removal. If medical miscarriage, then we have to do the urine pregnancy test 3 weeks after the procedure. So the risk of the gestational trophoblastic nucleasia after confirmed therapeutic abortion is going to be 1 in 20,000. Here is this point, okay? You have done this removal and then the chance of having this gestational trophoblastic nucleasia, that is going to be 1 in 20,000. That is the point, okay? So then another question, now we are answering different questions. So if she had, how should women with an elevated HCG after a possible pregnancy event be managed? So we have to refer to the Gestational Trophoblastic Disease Center. We have to consider for all women with persistently elevated HCG, either after an ectopic pregnancy has been excluded or after 2 consecutive treatments with methotrexate for pregnancy of unknown location. Your patient is having persistent bleeding like that. So if sometimes, it can be like, because GTN, if we have not been diagnosed and we have this failure to treat, then it is going to be catastrophic. Patient can die. That's why intensive chemotherapy, it should be done after there is this treatment of the unknown. Methotrexate has been given, so it should be followed by referral for the management. Very rarely in some women with familial raised HCG with HCG level between, like she has this familial issue, the baseline HCG level can be 10 to 200 international units per liter. So these women, they will have menstrual cycle and they can conceive. So low levels of the HCG elevation, they are associated with malignant female germ cell tumors and any epithelial cancers, including the cancers in the bladder, breast, lung, gastric, and the colorectal cancer. And low levels of the HCG elevation, they can also be caused by the presence of pituitary HCG or the presence of human anti-mouse antibody. Many things can be there, but they will not go into the minute findings. You should know that they can be of the pituitary origin or they can be because of the human presence of anti-human mouse antibody. These are the things. So the HCG protein, as you know that these are glycoproteins and they can present in many forms in both the serum, urine, including like intact HCG, pre-beta HCG subunit, like the nicked HCG and the HCG beta core fragment. They can exist in, these are different dimers, okay, different presentations. The HCG can be like in any of these forms, multiple forms. So the molar pregnancies and the GTN, they can produce all these variants of the HCG. These are variants of HCG, and the most routine kits, they are selecting the beta sub. They don't measure all subunits. They are just doing this beta HCG, which is the pregnancy specific like that. So after this, the what question can be asked like that? So the patient has persistent bleeding, or she had a diagnosed pregnancy, or she had like this pregnancy of unknown origin, unknown location. Both should be, and she has persistent bleeding. So again, send her to the regional center. That is the point. So when it should be done, like if they have irregular bleeding for more than 8 weeks after conception, after pregnancy event, then we have to send them to the, we have to do the beta HCG and we have to take the decision accordingly. So you should remember that less than 1% women, they will develop gestational trophoblastic neoplasia. They will return to normal after 8 weeks of the pregnancy event, less than 1%. If HCG, imagine you have a patient, her HCG level returned to the normal baseline, because it cannot be zero in the body, it can be like 2 to 5 international units. So if it has returned to normal within 8 weeks after any pregnancy event, then it means the chance of having GTN is going to be less than 1%. So if it doesn't drop to the baseline after like 8 weeks, then there is a chance that patient can have gestational trophoblastic neoplasia. That is the point, okay? So after, if like weak women should be investigated for GTN after a non-molar pregnancy. Non-molar pregnancy, we don't know that it was normal or not. So we will see that if she's having like persistent vaginal bleeding, then urine HCG test should be performed in all cases of persistent or irregular vaginal bleeding lasting more than 8 weeks after pregnancy event. And then if she has symptoms of metastatic disease, like she becomes breathless, she has dyspnea, she has hemoptysis or new onset seizure or paralysis, then they can occur very rarely. Then biopsy of the secondary deposits in the vagina, it can cause major hemorrhage, and this is not recommended. So any nodal lesions into the vagina, you are not going to do anything like that. The choriocarcinoma, it can be seen like the incidence is 1 in 50,000, but if the beta HCG level has returned to normal within 8 weeks, then the chance of having GTN is less than 1%. This is what I'm telling you, okay? So the case series, they have shown like GTN can be, the most common presentation will be vaginal bleeding like that. So anyone whose level is not returning to normal and she has bleeding after birth, we need to investigate her. Then another question, that if you are suspecting ectopic molar pregnancy in the women, then how you should be managing. So this is suspected ectopic molar pregnancy. So what we should do, that these women should be managed as any other case of ectopic pregnancy. So if they give you patient where is you're suspecting that she has ectopic pregnancy, but this is like molar in origin, so just follow the standard guidelines, okay? So you will treat her as any other case of ectopic pregnancy. And if there is a local tissue diagnosis of the ectopic molar pregnancy, that tissue should be sent to a center with appropriate expertise for the pathological review. Send the sample to the higher center and then follow their advice. Then what to do if there is a twin pregnancy and there is a viable fetus, and there is like second one is coexisting molar pregnancy. So women who is identified with this twin pregnancy, where the one is baby is viable and one is like the molar pregnancy. So and there is a diagnostic doubt. If the diagnosis is not clear, then of course you have to send them to the regional fetal medicine center. You can send, and you can send them to the gestation trophoblastic disease center. So in this situation, a twin pregnancy, one is viable and the other one is like molar, so they should be counseled about the potential increased risk of perinatal mortality and the outcome for the GTN. So here, what we will do, prenatal invasive testing for the fetal karyotype should be considered in the cases where it is unclear if the pregnancy is a complete mole with a coexisting normal twin or possible singleton partial molar pregnancy. So prenatal invasive testing for the fetal karyotype, it should be also be considered in the cases of abnormal placenta, such as suspected mesenchymal hyperplasia of the placenta. Why we are talking
But
about
then,
the
sorry, Dr. Aisha, can I ask a question? How did this perinatal invasive testing for the, like, because they take the blood from the mother, yeah?
Yeah, because
but then how they can differentiate in the twin pregnancy, because it's
so that's why, you know, they're telling you to send to the regional center. Why? Because they will be able to see that which one that they have the shared placenta or they have different things. So under ultrasound guidance, they can take the they can carry out the fetal carry. The prenatal, it is basically you are going to do it in the cases where it is not clear to you that what exactly they have. Is there any problem or there is nothing like that? Okay? So we are considering if fetal karyotype, if it is unclear whether it is partial or complete mole, and in cases of abnormal placenta, like the placental mass is like too big, like we are suspecting that there is mesenchymal hyperplasia of the placenta. I mean, anytime you are seeing anything abnormal, then you have to send them for the fetal karyotype. Since the experts are doing it, so they can take the fluid, they can take the cells, they can take the placental tissue under ultrasound guidance. That is what I'm telling you. Okay. So is this point clear now?
yeah.
Okay. So you have seen, now we're talking for the twin pregnancy, you have seen one seems normal and the second one looks like abnormal, right? Second one has molar pregnancy. So increased risk of early fetal loss like 50%, premature birth 36% in twin pregnancy, and then the incidence of the preeclampsia is variable and the rates can be as high as 20% for the preeclampsia. So while they did a series and they found that there were like only 4% chance of preeclampsia, but some other they have reported 20% chance, and luckily no maternal death was reported like that. Then they can also ask you, you know, this whole paragraph is very important. Okay? Why? Because, you know, it contains all important numbers. Like, what is the chance of surviving the baby? 51%. That is one thing. So, and it is not associated with an increased requirement for chemotherapy. That is one thing. So basically, I have told you that increased risk of early fetal loss, which is 40%, premature birth 36%, and the risk of PET 4% to 20%. Then if the birth is after 26 weeks, then 51% of the babies are going to survive, because if the birth is occurring before 26 weeks, then this number will drop definitely. And then what else we have to do? We have to register all confirmed GTD cases, whether they are single or like multiple here, like the twin pregnancy. We have to refer them to the regional gestational trophoblastic disease center like that. So this point is clear. Okay. Any problem here? Anything?
No, it's okay.
The same thing, that they should be sent to the registrar for the registration. So what should we do if we suspect a placental site trophoblastic tumor or epithelioid trophoblastic tumor? So all women with the placental site trophoblastic tumor or epithelioid trophoblastic tumor, they should be registered with the and cared for within a GTD center. So this is very important. Why it is so? Because all of them should go there if there is like localized disease. So it depends that it is a local disease or what. So if there is like localized disease, can you appreciate it? Localized disease, then hysterectomy is curative in many cases, right? So we are going to offer them one procedure, which is hysterectomy. Then if there is like you have seen the patient, but there is already like extensive metastatic disease. In that case, you need to offer intensive chemotherapy. It is going to play a major role because even in this scenario, even if you will do hysterectomy, it is not going to be helpful. So we need to give her chemotherapy. Is this point clear? Like
Yeah.
that? Okay. So localized disease, offer hysterectomy. Disease is distant, offer extensive chemotherapy. Then sometimes what can occur, like the placental site tumor, they can be atypical. Like you are seeing a placental site nodule or atypical placental site nodule, how it should be managed. So woman who is having like atypical placental site nodule and where the local pathology is uncertain, then she should have their histology reviewed centrally in the center. And all women with this atypical placental site nodule, what they should do, they will then be called up for the central review to discuss the existing data, perform staging investigations, and to determine further management. So multidisciplinary team review, where they have this atypical one. Because this atypical placental site nodule, it can progress to tumor in like 15% of the cases. So 15% is a big number. What do you think? So that's why if we are uncertain of the pathology, so we need to send them to the regional center for performing the workup and then they can diagnose it. This is atypical placental site. Okay, that is the point.
Yeah.
So 15% they can have the cancer. So now if this one is like a typical nodule is there, then no need for the central. Pay attention to this, see, just by changing one word. If there is
typical
atypical,
and atypical,
send for the review. Typical nodule is there, don't have to do anything because they can occur like that. So then another question they can ask you that who should be registered at the GTD center? So all women who have been diagnosed with GTD, they should be provided written information about the condition, detailed counseling and referral for follow-up by the GTD center, and then better outcomes when the patient is receiving care from the GTD center. Obviously, why better outcomes? Because these people have been trained to treat these conditions. That's why we are sending them. So registration, this is the minimum required standard of the care. Like they expect a better care, but as a minimum, we should do at least this much. That is the point, okay? Yeah. So then you should know that with the following diagnosis, they should be registered and require follow-up as determined by the screening center. Complete molar, partial molar pregnancy, twin pregnancy with complete or the partial molar pregnancies, then the limited macroscopic or microscopic molar changes which are suggesting possible early, complete or partial molar pregnancy, choriocarcinoma, PSTT, ETT, atypical node. Pay attention to the atypical node. Atypical node is there, so we are going to refer them. So risk of chemotherapy is already we discussed 13 to 16%. That is for the complete molar pregnancy. And complete molar pregnancy and for the partial 0.5 to 1%. Partial, the risk is partial, so we are giving chemotherapy to a lower number of the cases like that. Then optimum follow-up. What should be the optimum follow-up following the diagnosis? So first of all, the molar pregnancy. These are all normal questions. They are testing you. This is a very important guideline and read it at least 3-4 times before your exam. There was a complete molar pregnancy. Beta HCG returned to normal within 56 days of the pregnancy event. Pregnancy event that we did suction evacuations was spontaneous miscarriage or anything, or was birth or anything. Okay. So the beta ICT has returned to the baseline within 56 days. So the follow-up should be for 6 months from where? From the date of uterine removal, not from the date of the test, from the date of the removal of the condition like that. Okay. Then removal of the tissue. Then if HCG has not reverted to the normal within 56 days of the pregnancy, then what we will have to do, we will have to offer follow-up for 6 months from the date of normalization of the HCG. When it was normalized within 56 days from the date of the evacuation, date of the uterine removal. In the second one, in the 56 days didn't return to the normal, then we are going to offer weekly beta HCG, and then we will count 56 days from the 6 months from the date of normalization of the HCG. Okay.
So
For
we
the
go.
follow-up of the
Sorry.
yeah, that's okay. Please go on. No problem.
So we go. So in the second point, if HCG has not reverted to normal within 56 days of the pregnancy event, then follow-up will be for 6 months from normalization of the HCG level.
Yeah.
So we wait until
Yes.
the HCG is back to normal, and then we continue from that to 6 months.
Yeah, we'll count
Yeah.
from that. Okay.
Mhm.
Till that point, we have to provide her follow-up. Okay. We have to follow up for 56 months from the normalization of the. Now today it has become normal. Still for 6 months we are going to follow her up. Then we will stop the follow-up. Okay, that is the point. So this point, is it clear now? You did one
Yes.
patient
Yeah.
had complete molar pregnancy. You did evacuation, and then you have been doing this serum beta ICG, and within 56 days or within like 8 weeks, it has become normal. Then you will do the follow-up 6 months from the date of uterine removal. Okay, when you did suction evacuation. There
Yeah.
is a second patient. You remove the tissue, but in the first 8 weeks, serum beta ICG has not returned to normal. Then you will kind of keep doing this serial beta HCG, and when it will become normal, you will continue to follow our hub for another 6 months from the date when the beta HCG level became normal. That is the point. Then in cases of partial molar pregnancy, it is concluded once the HCG has returned to the normal on 2 samples which have been taken 4 weeks apart. Partial molar pregnancy, sample became normal, then we should take 2 samples. Then one sample has become normal, like on, let's say it became normal on March 4 and today is April 4. So today again we will repeat the level, and then after that we will say that she is fine now. She can be discharged safely.
Yeah.
Okay.
So
One
4
sample
weeks
is negative.
apart. Yeah.
4 weeks apart, 2 samples are required. If we don't, this is also like the addition in the guideline. So if 2 samples are not negative, then we will have to continue the follow-up.
Okay.
Then
Yeah.
women who have not received chemotherapy, they no longer need to have the HCG measured after any subsequent pregnancy event. So any women who have not received chemotherapy, you remember before we used to say that everyone has to go for the chemo for the follow-up. But the guideline says that if you have not received any chemotherapy, in that case, you don't have to offer her like that. Uh, in the subsequent pregnancies, she should not be coming like that. That is the point. So that is one thing. And if no chemotherapy is received, then the chance of having GTD in the subsequent pregnancy is going to be very, very, very low. Like the guideline will tell you, in that case, the chance of having this one is going to be 1 in 4,011. So we don't have to offer, and if they didn't receive any chemotherapy, so we don't have to put them follow-up. That is one. We don't offer it to her. If she did no chemotherapy, no follow-up after the subsequent pregnancies, the chance of having cancer, GTD, not GTN, GTD will be, the risk will be 1 in 4,000. So previously the risk was like 1 in.
So what about in the previous point, like if she was like partial and she didn't receive any chemotherapy?
Yeah.
Do we
So
follow that?
partial, the chance is very, who is going to develop, who has higher chance of GTN? The one with the molar pregnancy, okay, and then the
Yes.
one who received chemotherapy because they had higher grade of the disease, right? So
Yeah,
after each pregnancy event, they will be going for follow-up. But here we had a molar, but in this molar, what we have, like the risk figure score was very low, so we are not going to offer her, and she didn't merit this chemotherapy. So for that patient, we don't have to offer her. We will tell her that she has no risk of GTD after next pregnancy like that. So we will not offer her the follow-up like that. because before we said that anyone who is receiving chemotherapy, they should be coming to or reporting to us after each pregnancy outcome, after each subsequent pregnancy. But if she
Yes.
didn't receive chemotherapy, then we don't have to give her any follow-up after for the subsequent pregnancy events. That is the point.
Okay.
That is the point. So, and we don't have to check their serum beta IgG because no chemotherapy received, so low risk now. Now, if so, is that point clear?
Yes, yeah, now it's clear, yeah. So
Yeah.
this point is clear like after normal pregnancy.
Yeah, like that.
Yeah.
That is the point.
Yeah.
So, what is the optimum treatment for the gestational trophoblastic nucleasia? So as you know that we have to rely on the FIGO scoring system. That score was developed in 2000 and that is for the assessment. Why? Because we have to be very careful like what treatment should be given and what should not be given. We should know that PSTT, this is also SPA, the central site trophoblastic tumor, and the ETT, these are recognized as variants of GTN and they may be treated with surgery because they are less sensitive to chemotherapy. The SPA question is that which of the following is least responsive to chemotherapy? Or they will ask you that which of the following tumors should be removed surgically? PSTT, ETT, they should be removed surgically. That is the point. So
Yeah.
as you know already that the FIGO scoring system is very helpful in understanding the stuff. So if the score is less than 6, then we have to offer mono agent therapy. Mono agent therapy, and if the patient is single agent therapy, and if the score is like 6 is more than 7 or higher, then we have to offer her multi-agent therapy. Don't try to remember all of this thing. Just I want to highlight one thing. You know, if you will come here, here is a score of 0. See this one very clearly. Lung metastasis is there, then the score is going to be 0. This is 0, 1, 2, 3. Okay. Lung metastasis 0.
0, yeah.
So in the exam they try to play a trick that they will give you something like the patient is there and she has hemoptysis, so it is not going to affect the score, so you need to give her mono agent chemotherapy. That is the point. Okay. So if the score is 6 or less, and 100% cure rate for such women. But if the score is 7 or greater, then the chance of then with the single agent, then we have to give her multi-agent therapy. Okay. So multi-agent therapy, you know that you are going to give that in the form of AMACO, like that. Okay. So the single agent therapy, we are giving methotrexate. How do we give that? We give injection or on alternate days. Intramuscular methotrexate is given, and on one day we are going to give folinic acid for 1 week followed by 6 rest days. Then next week we can give them methotrexate again followed by for 6 days by the folinic acid. Okay. And if the score is like more than 7, in that case you will have to give like multi-agent therapy. And in multi-agent therapy we are going to give them we can give a combination of the drugs. We call that like the AMACO, and in the AMACO we can give a combination of methotrexate. You know, the methotrexate is also included here. Methotrexate, dexamethasone, ectopic, cyclophosphamide, vincristine. Okay, all of these are making up AMACO like that. And we have to continue the treatment until HCG returns to normal, and then further 6 consecutive weeks. We have to give for 6 weeks. And if in a woman, you know, that is an important point, like they found this one, that if the score is more than 13 for some unlucky woman, then what will happen? This is an independent risk factor for developing, for the risk of death will increase like that tremendously.
Recurrence.
Okay. So if the score is more than 13, highest risk of early death, which means the death can occur within 4 weeks. That is very scary, but if the score is like 13, So then they are at risk of death. So we have to pay a lot of attention to them. If the score is more than 13, so they can die within first 4 weeks. So which is like very scary. And why they can die if the score is more than 13? Because they can have bleeding into the organs, or the disease will be resistant to the drugs. So what do we get? That these patients, they can die because the stage disease was advanced, and what happened? They received the chemotherapy, but still they can die, but they were resistant to the chemotherapy, or they developed the bleeding, and that bleeding too occurred inside the organs, and that's why the patient can die. So very important to have clear diagnosis and management. And you are going to get a SBA on this point, that if the score is more than 13, she has higher risk of early death, that is within 4 weeks,
4 weeks
due to bleeding into the organs or multi-drug resistant disease, because now we cannot help this patient like that. Okay. So
Yeah.
if you are suspecting that this patient has already developed like GTN, then what will happen? So you are suspecting choriocarcinoma. So it means that you will have to offer more extensive investigations into the specialist centers. Like maybe you will have to request CT, contrast CT chest. You will have to do contrast MRI pelvis and head, including the Dopplers and ultrasound of the pelvis and the HCG when you are suspecting choriocarcinoma. So that's why it is very important. And then the incidence of the placental side trophoblastic tumor or epithelioid placental side tumor, what is their incidence? So the incidence is like 0.2% of all tumors, and both placental side trophoblastic tumor and epithelioid trophoblastic tumor, they produce very less amount of the HCG. That's why they're not producing the HCG, and we cannot like give them. They are resistant to the chemotherapy like that. So that's why they are more chemo resistant. Why? Because they produce less HCG. They are confined to the uterus for longer periods of time, and more often they are going to involve the lymphatics of the person like that. And they are not, and the PSTT and the ETT, to treat them, we don't follow the FIGO scoring guidelines. Why we don't follow that? Because we already know that these two tumors are not going to respond to the chemotherapy, so no need to cause any, so no need to give it to them like that. So the patient was taking like multi-agent chemotherapy. What can happen to her? She can develop secondary tumors, like she can develop lymphoma, leukemia. She can develop that one, and she is likely to have earlier menopause. But this one they have removed from the new guideline. That is one.
Okay.
So then you should know that there are certain important prognostic and the factors for this PSTT and ETT. So most important prognostic factor for the adverse outcome is that interval to the presentation from the last known and
Sorry, Doctor Aisha. Can I follow you, because I don't know where are you now?
Come back. Yeah. The most important parameter which is helpful into following this pregnancy, that is this one. This one.
Yeah. Okay.
12 months from the end of the index pregnancy. So that is most important factor when you are following up a pregnancy like that. Okay? So the major important prognostic factor for what? For the PSTT and ETT. Interval to presentation from the last known and the presumed causative pregnancy. Like if the patient is like more than 48 months after the last pregnancy, and she has developed its PSTT, then 50%, 100% death rate. If it is this is opposite. Like if lot of as the time increases, that more than 48 months, then the chance of death will increase. More than 48 months, like she has developed this PSTT 4 years after having this molar pregnancy, or any that pregnancy where we got this molar tissue, then the risk of death will be 100% like that. But if this PSTT or ETT is diagnosed less than 48 months before from the previous
The
pregnancy where the
pregnancy.
motor pregnancy was there, then the risk of death will be like 50%. Okay, that is the point. So the treatment is because they are resistant to the chemotherapy. So maybe they are treating with the radio, like a lot of the stuff is there. So that is also a poor prognosis. Similarly, if the tumor is already in stage 4, if you will come here, all of this information is given here. This paragraph is very important. PSC, and they are making up like 0.2% of all GTT. And the most important factor is that when they are occurring after the incidental this one pregnancy, like if they are occurring more than 48 hours after the previous pregnancy, 100% death. And if they are occurring within 48 months, then the chance of death will be 50% like that. So stage 4 disease, it has now emerged as an independent poor prognostic factor. Like the patient presented and it was already stage 4. So in that case, it will play a very important role in the management of PSTT and ETT when it is, and patient will need extensive therapy. Okay? So here the surgery is going to play a vital role. So if there is stage 1 disease, we should be offering hysterectomy because that is the mainstay of the treatment. You can see here, stage 1 disease, offer hysterectomy. Okay? So if the disease is like advanced, then we will have to give intense platinum-based combination agent therapy. That is required if the interval is more than 48 months. So the interval is more than 48 months, then you have to give the platinum-based chemotherapy. High-dose chemotherapy with stem cell recovery can also be offered, or the treatment immunotherapy, or we are going to offer them platinum-based intensive therapy. This paragraph is very, very, very important. Mark this one. Okay? That is the point.
Okay.
So is that point clear now? Because
Yes,
basically
it's
they
clear.
ask you about the different types, and then they are going to ask you about the chemotherapy. So chemotherapy is very important. So you have given the chemotherapy. Now the patients, they are always asking you one question. They have suffered a recent loss, so they will be very much interested in asking you that when can I conceive again? Because she has a loss, so maybe she has some conditions, she wants to have more babies like that. So what is the safe period? So we have to tell that they should not conceive until the follow-up is complete. Like the woman who has taken this chemotherapy, then she should not conceive for 1 year after completion of the therapy. And they should take, this is done as a precautionary measure so that her treatment will not prolong, and it will not interfere with the monitoring of the treatment process like that. Because now the serum beta ICG due to a new pregnancy, it will start increasing, and then the chemotherapeutic drugs are not safe in the first trimester of pregnancy. Okay. So for 1 year, they should not conceive if they have received chemotherapy. Then women who have a pregnancy following a previous molar pregnancy, which has not required the treatment for the GTN, then we don't have to send the post-pregnancy HCG sample. Why? Because we already read that if we didn't require any treatment, we don't chemotherapy, any treatment, we don't have to do anything. So then histological examination of placental side from any normal pregnancy after a molar pregnancy is not indicated. Like last time she had a molar pregnancy, now she has come to you with a normal pregnancy. So now you are not going to send her samples for the HCG. Previously, you remember we said after each given normal pregnancy, we use send for the to exclude the beta ICG, to exclude the chance of having this molar pregnancy. Now, if you will go to the guideline, it says that the chance of having, like the risk of further mole is less than 1% when the woman had like a molar pregnancy. Like that.
No chemotherapy.
The chance of having recurrence is like less than 1%. That is one thing. Okay. So then what else can be there less than 1%? So you don't have to, you have to tell her that it is very low. So if the previous was molar and she didn't need any treatment, then we don't have to send any HCG samples after pregnancy. Then
placental tissue,
the same thing, like now previous molar, now normal, so we don't have to send anything. So, but we need to tell the patients, like if the patient had like previous molar pregnancy, then 25% higher chance that they will have a preterm baby. So some effect will persist like that. Okay? So previously there is like molar pregnancy, so 25% chance that she is going to have increased risk of 25% increased risk that she is going to have a preterm. That is the point.
Okay.
So, but if he has like whereas women with at least one birth between the molar pregnancy and the index birth, they were at increased risk of large for gestational age birth and stillbirth. If you don't go into the details, just remember previous molar, then the risk of preterm 25% increase. And if there was like one birth in the molar pregnancy, and then the index birth, then what will happen? There is going to be a risk of the large for gestational age and the stillbirth. These are the points. So a few things in the guideline are like very confusing, but you just remember that at least one birth between the mole and the index pregnancy. So last one was molar, and now is this pregnancy. So the chance of having large for gestation age baby, it will increase. That is the point. Okay.
Okay.
Then the woman had this. Hello, yeah.
Yeah.
So what are the longer term complications? So overall cure rates, they are almost 100%. Okay? That is the point. Long term outcomes. So cure rates are 100%. Further pregnancies, they are achieved in approximately 80% of women while following treatment for the GTN with either methotrexate or multi-agent therapy in both conditions. So she's getting single agent or she's getting multi-agent therapy. They are going to have like a good birth rate, that is 83% exactly given into the paragraph. But there is like menses, they will stop during treatment, but nearly always they will start having this menstruation within 4 weeks, after 4 weeks to months after the chemo completion. Then no overall increased risk of second cancers if they're treated with methotrexate or MRT. But there is going to be increased risk of premature menopause when they are treated with combination agent chemo. So if the age of the woman was like 40, then the chance of having this premature menopause, that will be 13%. Okay? 13% before the age of, by the age of 40%. And by the age of 45 years, how many they will have? And 36% by the age of 45 years. This is when they have received a combination therapy. So single agent therapy is not going to cause this premature menopause. That is one. Okay. So then advice for near 40 years. So we need to tell the women if they are like 40 years, approaching 40, we will tell them that if we are giving them high dose chemotherapy, then there will be impact on her therapy, on her reproductive potential. Then sometimes they are unlikely to regain normal ovarian function once they have received chemotherapy for the GTN like that. They are unlikely to regain ovarian function. That is one thing. Then AMH, that can be misleading in such cases. We are not going to rely on the AMH for seeing their ovarian reserve. That is the point. So then, regarding their another sticky area is that for the contraception, what should be done? So let's go to that quickly because it's a very lengthy guideline like that. So all of this is given here, okay? So let's go to this one. I put that one also here, that contraception after gestation trophoblastic disease. So they all should provide
Dr. Aisha,
the women.
Dr. Aisha, sorry to interrupt you. It's just it's Maghrib now. I want to pray and I don't know.
This conference will now be recorded.
So regarding this contraception after gestation trophoblastic disease, we know that we need to give full guidance to the patients, and the contraceptive counseling is provided. Care should be taken to ensure that women, they do not feel under pressure to choose a method of contraception. So they have to choose it with their choice, and you have to give her full information. That is one thing. and you have to tell them that they should avoid subsequent pregnancy until GTG monitoring is complete, and effective contraception should be started as soon as possible as sexual activity and fertility. They may resume soon after gestational trophoblastic disease. Then we should know that women they should adopt a person-centered approach when providing women with the contraceptive choices, and we have to ensure that they have been given timely information and that is up to date. Okay? So we need to reassure that they are not feeling any pressure, and we have to tell them that what are their chances of having the gestational trophoblastic disease and how they can prevent it. If that cannot be prevented, but how they can prevent the pregnancies. So all LARC methods are very good for them, and they should be offered to such women who had this treatment for the GTD. And then we have to tell them that they can also use, if they don't, we need to tell them that LARC methods, they should be discussed with them. Then we have to tell them that the progesterone only implants, they can choose them, and who are medically eligible, and they can be initiated, these methods can be initiated immediately after the treatment of the molar pregnancy. Then women who are unable to be provided with their chosen method of contraception, then they should be referred to the other centers, and then a temporary bridging method can be offered, like we can give them barrier method. Then service should have agreed pathways for the care of these women who have these problems like that. So we need to provide them good with good guidance, and they can use the barrier method. And then usually once the beta estrogen level has returned to normal, then they can use a combined hormonal contraception. And IUCD usually we are not inserting. Why? Because there is a fear of having uterine perforation. So we'll talk about this topic in detail once we are discussing contraception. Thank you very much.